This program is sponsored by the Spine and Orthopedic Institute at St. Vincent Charity Medical Center. Quality you can believe in. And co-sponsored by the Joint Implant Surgery and Research Foundation, dedicated to the advancement of total hip, knee, and shoulder surgery since 1971.
Well, now I'd like to take a few minutes to talk a little specific about design features of current hip technology and some of the newer technology that we're working with. And Lou, you and I have gone way back in doing SROMs from the mid-'80s, and it certainly has been an excellent hip, and we had a scientific exhibit at the Academy in '06 with Hugh Cameron where we reported on 17-year results. And I don't think we reported on any aseptic loosening on, I think it was 500 cases. But certainly we would consider this old technology from a geometry point of view on bone removal. And I wonder if you might just comment on your experience with the SROM and how possibly today some of this newer technology that we're talking about is a little bit more conserving of say, hard tissue and maybe soft tissue.
The SROM stems worked well. I used it, started back in around 1986 or 85 with the stem, and I used it to solve a problem I was having with some of the chrome cobalt stems that were available at that time, when that was stem pain. People would have pain in their thigh after their total hip replacement. And I thought it was related to a mismatch on the strength of the bone versus this, or stiffness of the bone versus the stiffness of the implant. And the SROM, one of the things it had a clothespin design. It was titanium, so it was a little bit more flexible. And I hoped that this would have eliminated that problem. And it did. And it also solved another problem, and that is allowing me to adjust the anteversion of the femur to get the anteversion where I wanted it. It was excellent for revision cases. It was excellent for my dysplastic cases. So it was a very, very useful stem. It's a very, but it's a very technically demanding stem for maybe the surgeon, but more importantly as operating room staff, because you had to repair distally with a reamer. Then you had several different sizes of proximal conical reamers. Then you had to mill this medial calcar. And then you had an infinite number of choices relative to neck length, and an infinite, obviously, variability with your anteversion. So to master the nuances of the stem did require you being committed to the stem, learning the subtleties of the stem, and your staff to be committed to it, to understand the instrumentation. So it was a great device, but it was, I guess you'd call, a labor-intensive device. I still use it to this day for certain cases.
One of the limitations of the SROM in today's current technology, I would say, and want your comments on if you have the stem down and if you want to tweak the biomechanics, offset or version, you really have to withdraw the stem, which can be difficult to take a fluted stem out. And where some of the newer technology, and I know, Dr. Mackel, you've had an opportunity to also work with this, which is more of an SROM style, but has proximal modularity. And wonder if you both might just comment on that part of the technology of separating that junction versus some of the old monoblock type technology.
Well, I think I've found that these modular stems really give you the opportunity to look at your anatomic offset, anatomic version, and depending on where your acetabular component is, to really make some very fine-tuned adjustments that you can't do with a monoblock stem. I still use monoblock stems, but I continue to find difficulties getting my leg lengths equal, getting my abductor tension corrected. And so I like the concept of this modularity. It just takes another process of learning when to make the adjustments, where to make the adjustments, so that you can maintain your leg lengths and to maintain your abductor tension.
And Dr. Rubash, I know that you're, I think, currently using a lot of tapered type designs.
I am.
And I believe you also have some experience with different types of proximal modularity. And you know, this is just one example of a tapered stem. Could you comment on why you feel that type of profile, stem profile, may be better to as opposed to a straight stem or some sort of trapezoidal design?
Well, getting back to the SROM, I use the SROM in my practice for femoral deformity and for very small sizes. And actually, I found it to be wonderful. The thing about the first generation stems was that fixation was an issue, but not with this particular stem. This stem in-grew, it was stable, unlike some of the other first generation stems, and it has such a great track record because it's a great stem. But you're right. I mean, the first time I used it, I mean there was more equipment in the room than patient anesthesia machines and everything else, and it was just too much. And we would peel it down to just 2 or 3 cases. Those are the ones we want. The next stem that I used was a cylindrical stem, which again required distal reaming and proximally porous coated. And again, fixation wasn't an issue. Those stems in-grew, but again, it was more and more difficult. The thing I like about the tapered stems, and particularly just the ML taper stem, without an anterior-posterior taper to it, is that their ease of insertion, the reproducibility, and how closely the rasp size matches the implant size. So that when you get your rasp in and it's seated, that same stem that corresponds to that rasp is going to go in and it's going to seat about the same spot. They are very, very secure. And that's what I want. I want to do as little disruption as I can of the femur, and I want to get that stem from its initial insertion time to be stable. I want it to be stable in varus valgus, and I want it to be stable in rotation. So tapered stems will do that.
Let me ask you one question on tapered versus straight stems that have a geometric shape where we were able to mill the shape and get a precise location. It appears that a lot of tapered stems are what I would call a mid-stem fixation point, and that point can be variable. And I know Dr. Rothman has lectured pretty extensively that don't worry about over-lengthening the limb. Joint stability is the first and foremost goal, and often he'll